Good day, and I thank the Harvard Global Orthopedic Collaborative for giving me this opportunity. So today I'm going to cover on neglected fractures, most probably the neglected acetabulum fractures and neglected dislocations, mostly the hip. There are no disclosures in my talk. So coming to the summary, the key aspects which you are going to see about the neglected posterior wall fractures, neglected hip dislocation, and how generally we treat them with a few case examples. So coming to the introduction, acetabular fractures are having an incidence of around 3 patients per 1 lakh per year. They have a bimodal age group distinction. So generally in distinct age groups, generally it involves in young patients, which are mostly following RTA from fall from height, etc. And also in older patients, which follow the geriatric fracture pattern, which are mostly have a anterior column plus posterior hemitransverse. So that is the most commonly type seen in the geriatric fracture population, and more incidence is in developing countries. The neglected fractures due to the delay in the patient presenting to the hospital and delay in their knowledge, and most probably they go to a native bone setter. So most probably these are the conditions which make them delay in presenting with this condition, and they present with adverse condition where the management is generally literally impossible, mostly needs a total hip replacement. So the term neglected is often debated in literature. Generally, from literature, it is seen that a duration greater than 3 weeks is called as delayed or neglected fracture, mostly neglected acetabulum fractures or hip dislocation. Coming to the first part of our talk, what is neglected posterior hip dislocation? Because posterior hip dislocation is most common where the limb goes into flexion, adduction, and internal rotation. And generally, a dislocation lasting more than a week, which is generally unreduced or which is not fully reduced, or it is reduced having a posterior wall fracture, which goes into a neglected dislocation more than a week, or generally 2 to 3 weeks, where the patient present towards late with the shortening or difficulty in walking, pain, and etc. So, what are the most probably in the present more than 3 weeks or so? What are the issues? Is presence of fibrous tissue in the acetabulum, also presence of starting of capsular contracture which goes on more than 1 month or 2 months, presence of loose intraarticular subchondral fragments, intraarticular fragments, presence of labral tears and invagination. And most of these fractures are associated around 18 to 33% with posterior wall acetabulum fractures. So generally they lead to a later on stage due to the medial circumflex femoral artery which gets kinked, because which goes to the posterior part, which goes to the superior part of the quadratus femoris and under the obturator externus and between the short external rotators, and come and supplies the through the ligament of Weisberg to the superior retinacular artery or the lateral epiphyseal artery. So in neglected posterior hip dislocation, it gets kinked and leads to a increased incidence of avascular necrosis of the femoral head. And also due to this more than dislocation, the reduction of neglected dislocation leads to more of the peroneal component of sciatic nerve palsy, and mostly the lumbosacral nerve roots are also most commonly injured. So the next common part with this neglected acetabulum fractures and neglected hip dislocation, we have the neglected femoral head fractures. Generally, these are rare and generally they involve the infrafoveal fragments, and mostly if you can do an excision, fixation in chronic cases are generally difficult, or generally in long cases is advised to do a total hip arthroplasty in delayed or neglected cases. Coming to the neglected posterior wall or column fractures, they are the most common type, around 18 to 33%, and they may be a single large fragment of the posterior wall or the column, or they may be presence of multiple fragmentary paths where they go into a fibrous non-union or a malunion type of scenario. So what are these problems in this neglected posterior wall or column fractures? So there is a femoral head damage due to the constant rubbing of the femoral head over the acetabular posterior wall fragment, and also there is abnormal callus formation. There may be a malunion of this fracture fragment, or there may be an organized non-union. Also, most commonly, these are associated with local bone center massage and other things, leading to heterotrophic bone ossification, leading to a lot of acetabular bone loss and macerated acetabular fragments. So these are the commonly neglected scenarios. We see the hip dislocation, the femoral head fractures, and the neglected posterior wall or column fractures. So generally, the treatment option in these comes into three categories. One is a conservative option, or it can be involving the fixation, or the replacement is a total hip arthroplasty. So what are the difficulties? Generally, the fixation part generally we commonly use in when there is a large non-union or a presence of a large pelvic discontinuity, presence of acetabular defects. So we want to fix the column and help in forming a good bone stock for future cup placement. And when doing in primary total hip arthroplasty, in these cases, doing a THR is generally difficult. Because of the extensive soft tissue dissection, we have to have increase in bleeding, increase in extra heterotrophic bone ossification changes, and always we have to do a posterior column stabilization because the column hold is at the posterior column, and generally presence of acetabular defects, a cup cage construct or flange cups or cages cups with metal augments are used. So generally this is the scenario or algorithm. Neglected fractures, more than 21 days, obtain a CT scan, see whether it is a elementary fracture pattern or an associated fracture pattern. What are the elementary? Generally, they have the wall, column, anterior part, posterior wall, posterior column, or the transverse fracture. Are the associated both columns, the T type, which involves the obturator foramen, anterior column, posterior hemitransverse, and transverse with the posterior wall, and also the posterior wall with posterior column. So generally in elementary type, try to fix the fracture. And if it goes for avascular necrosis, we have a definitive good bone stock for a future total hip arthroplasty. If they are associated this, when it comes to non-union, achieve the bone stock, then go for a total hip arthroplasty. If it is a malunion, you can directly go for a total hip arthroplasty. So this is a case from literature we shown. We have a non-union of the transverse fracture. So what are the problems in non-union? So the problems in non-union is extensive fibrous tissue, which has to be excised, and maximum mobilization of fragments, whichever possible, has to achieve, and standard reduction with K-wires or the Jungbranch clamps, and reinforced with posterior column plates or bone graft with lab screw. And generally, you in these non-unions, you try to achieve a acceptable posterior column for a cup placement. So anatomical reduction is generally not aimed in this fracture, just a posterior column or wall support, and acetabular defects is assessed after fixation for options. So this is the algorithm. Fracture of non-union, it has a wall non-union or a column non-union or transverse non-union. In wall or column, you try to achieve a acceptable reduction possible, add bone grafts, iliac crest bone graft, or any other allografts are present, and do the necessary posterior column or the posterior wall plating, and achieve a substantiate bone stock for a future THR. Even for putting a primary cup in this, you should have a posterior column for support. So perform a CT scan, elementary associated as we discussed, and this article from Silcott Journal published in 22 says that you do an MRI scan if we have associated intra-articular fragments, femoral head chondrolysis, or any impacted head or indented fragments which can lead to a future avascular necrosis, go attempt have a no attempt open reduction and go for a total hip arthroplasty. So when you are going for attempting fixation, so what are the challenges? So there generally be a marginal impaction, dome impaction, presence of the impact, the subchondral fragments which are invaginated in size. So try to retrieve them. If you want, you can do a trochanteric osteotomy or safe surgical dislocation. Try to retrieve them. Try to temporarily hold with K-wires, use subchondral screws, and try to use additional plates or spring plates, whichever this. So long term, what happens is the constant pressure of the non-reduced femoral head over the posterior wall causes smudging and loss of bone fragments. So bone loss is there. So that causes the superior and posterior wall loss. So that is the reason, and so you can have to augment. So coming to conservative, how effective is the conservative management in this neglected this? So in various type of articles show that generally 56% of conservatively treated acetabulum fractures has good to excellent results. So this was little surprising, and they tried to maintain a good opposition of these fragments generally to have a NMAS or a callus to have a sufficient bone stock for future arthroplasty by giving a bed rest, longitudinal and lateral traction to prevent the impaction of the femoral head or smudging of the femoral head over the posterior wall or posterior column fragments to prevent dissolution. Then some articles say that initial reconstruction of these fragments is detrimental to future arthroplasty. If you do it wrongly, leads to bone loss much more than the conservatively managed. So conservative definitely has an option depending upon the geriatric patients, it can be done. So other uncommon obstruction is excision arthroplasty. Hemiarthroplasty in geriatric age group you can do, but generally try to avoid because there are chances of protrusion in these type of cases. So this paper from Indonesia has a neglected acetabular fracture fix or replace. In this, evidently all the neglected fixation which they have fixed leads to a total hip replacement with a minimum 1 year following a TH following fixation can lead to a total hip replacement. But what this fixation in these studies says that they give an adequate bone stop for a good acetabular cup placement. So fixation, generally elementary fractures are fixed. You can go for a Coker Langenbach approach if it's the posterior or anterior. We have 4 approaches. Go for a iliofemoral approach with AS osteotomy or anything. And in these cases, neglected cases, you may need a trochanteric osteotomy. So plan it. If you are doing a trochanteric osteotomy, try to go through the Gibson's interval. Do a trochanteric osteotomy, mobilize the fragment posterior wall, fix it with KYS and put a plating plus or minus iliac crest bone graft. Why iliac crest bone graft? Reconstructing the posterior wall because the concavity of the ilium matches with the concavity of the posterior wall. Hence, iliac crest bone graft is generally better in these type of patients. So what are the complications? So most commonly, we have a high incidence of foot drop due to the peroneal component of the sciatic nerve getting involved because of the extensive soft tissue retraction and dissection, everything. There is a definitely increased incidence of blood loss, systemic complication, anesthetic complication due to long duration surgeries, increase in infection chances, and definitely heterotrophic ossification. So this is a case where a 2-month-old posterior dislocation with a wall fracture which has been neglected. So in this CT scan, you can see how the posterior wall is postero-superiorly placed. So since this case is presented to you, so the first only you have to plan that with the normal Coker-Langenbach approach, it's difficult to approach the fragment of the postero-superior. So you have to do extensive release of the gluteus medius and you have to give a good retraction to fix the fragment. So plan for a trochanteric osteotomy, go for the Gibson's interval, and you do a trochanteric osteotomy, how we have done like this. So this is the trochanteric slide osteotomy, this is the vastus, and this is the gluteus medius. And in that you can see the posterior wall fragment. So this posterior wall fragment was temporarily held, mobilized, and fixed. And we have done a double plating. Double plating has been done. So these are the post-op X-rays. So a wall and a column plating has been done. So this is a follow-up at 3 months. So the patient is doing well. So what happened? So you have fixed or you have done a neglected this. So how useful is this Plaparowski defect classification? So generally a neglected hip dislocation, neglected acetabular fractures, posterior wall where the femoral head is impinging on the posterior wall, posterior column, and it definitely can lead to defects. So most probably our interest is type 2B and type 3A, where there is supralateral migration of less than 2 centimeter, more than 2 centimeter. And so this is the Paprowski defect classification, and AOS generally divides into cavitatory deficiency and segmental deficiency. So we'll see to that how we manage the cavitatory deficiency, segmental deficiency. So coming to the defect. So if it is a cavitatory, it can be a medial or a peripheral. So generally in cavitatory defects, impaction bone grafting is it can be done, and we can go for a associated with cup placement. So generally with the medial display, medial wall or medial bone loss, or when the head is pushed medially, there is a protrusion. When there is less than 5 mm, no bone graft is needed. Generally the column support is enough. If generally more than 5 mm of this, so bone graft or augmentation defect or a mesh with the bone graft is generally needed. So major periacetabular loss, cup cage construct is needed. So coming to the segmental defect. So it can be a posterior, superior or a medial. So generally less than 30%, try to do a structural bone grafting, plating, use the bone grafted and the plated column for a good primary fixation of the primary cup. So you can use a highly porous cup, and if it is more than 30%, and if it is 30 to 40%, you can try using a highly porous cup with a good porosity like the Gription cup, or more than the 30%, go for a bone graft or a cup cage construct. So what are the issues on the acetabulum side? So how do you manage the acetabulum side? So most probably these cases, neglected cases, you need a grafts, autograft or allograft, iliac crest graft. You may need acetabular cups. So a good implantology is needed, armamentarium is needed, a good preoperative planning is needed. You might need a superior defect. You may need a trabecular metal augments, reinforcement cages, posto-superior a graft is needed, or you can use augments. And when there is a large this, you can use a titanium or a mass implant, which is a metal coated implant, which is generally tantalum implants. So we can cement in a cup. You can also cement in a dual mobility cup to prevent dislocation because of the soft tissue damage. And in cases of pelvic discontinuity, try to at least get the column fixed with the plate and try to put a larger size cup. So total hip arthroplasty. So generally the posterior column support is needed for the cup placement. So generally the cup has a triangular support, or the most primarily 2 points of support are the anterosuperior and the posterior inferior, where the cup is placed where the ischial and the ilium. So these are the 2 column support. And generally when you have column disruption, the most important column support is the posterior column. Try to fix the posterior column with the plate and go for a highly porous cup. And you can use a multi-hole cup, put the screws in the ilium, ischium and the pubis to support the cup and to prevent abduction failure of the cup. So what are the THR problems when doing the THR? Extensive soft tissue release is needed, and also definitely most of the cases a pseudo acetabulum gets formed. Identification of the true floor of acetabulum is generally difficult. Go for a towel placement or fluoroscopy, and most probably these screws might or may not interfere with the cup placement. So if it tries to interfere, try to remove those screws. And if you are in a position to remove the plate or non-union, try to put a lag screw and later put a plate more posteriorly and try to get a primary cup placement, or try to use a cup cage construct. High hip center may be get accepted in these cases, and to see to avoid sciatic nerve palsy. So in this case, if you see, there is a case report which is reported from India, where there is a pseudoacetabular with a neglected posterior hip dislocation. So they did a staged approach. Initially, they did osteotomy, given traction, brought down the femur little, then they placed the cup in the true acetabulum. So what are the additional procedures? Generally, the additional procedures needed are the subtrochanteric osteotomy or the trochanteric slide osteotomy when there is defective problems in reduction. THR implant options, uncemented dual mobility, cemented dual mobility. Cemented dual mobility is a good option when using a cup cage construct. Constrained implants in view of abductor dysfunction. So this is a case of a 51-year-old male, right hip pain, FFD of the right hip. He had a neglected anterior column fracture with quadrilateral plate injury. So this is the X-ray which presented at 1 year. So you can see the intact ilioischial line. and this is the femoral head, and there is a medial where the head is pushed over the quadrilateral plate. So there's a medial defect, and you can see there is a loss of the teardrop. So there is definitely a medial wall defect is there. So these are the this. So this is the CT scan. So this is the posterior column, and these are the anterior column. So this is the medial wall. So this is the posterior part. This is the anterior part. So this you can see where the head is protrusion inside, and there's a quadrilateral plate damage. So what difficulties we had in this case, dislocation should be very, very careful, very, very subtle. And if you're not able to dislocate, do an in situ neck osteotomy, create a gap, and you can rebend the head. You can use that as a graft, or if possible, you can dislocate it en masse. So this we were lucky to dislocate it en masse. Neck osteotomy was done. Medial only thin membrane was there. So all these bone chips from iliac crest and from the femoral head was taken. It was filled in, and reverse reaming was done. Generally, reverse reaming is whether it can be used or not can be used is a debatable. And uncemented press fit cup was done. Limb length equalized and no sciatic nerve palsy. So this is the follow-up X-ray, and this is the CT scan at 1 year. This is the follow-up at 5 years. You can see that the medial wall or the ilioischial line and iliopectineal line is somewhat regained, and there is not much protrusion. The cup is in good place. The femoral stem is in good place. So these are the different views. So this is the patient with having a sitting cross-legged, and this is the walking video of the patient is asymptomatic and full non-weight bearing. So full weight bearing is walking. So this is the CT scan showing this. So this is the medial bone incorporation is there, but some amount of radiolucency is there, but the patient is asymptomatic, so we can wait and watch. Patient is 55 years. Post-operative protocol in all these cases, DVT is very, very must. So DVT prophylaxis is needed. Systemic antibiotics is needed. Indomethacin to prevent the heterotropic ossification. Mobilization done as per intraoperative stability. So this is another case where a neglected posterior hip dislocation, posterior wall acetabulum fracture fragment, dislocation was reduced, subluxation was persisting. So this is the pointer showing the wall fracture. So this is the, and also as a femoral head defect. So these are the cases where initially they could have done a total hip arthroplasty also, but we tried a fixation, Cocker-Langenbach, posterior wall reduction, lag screws, column plating. So this is the post-operative this. So this is the post-operative CT scan, follow-up X-rays. And slowly we can see when over the months, and now it is nearly 6 months, nearly it is 9 months, completely the superior part of the femoral head is completely lost, and there is a complete bone void is there. So we planned in for a painful in walking supralateral defect. So this is a CT scan showing the defect of the head, and this is screw penetration is there. So this is the defect is there. So we done a CT scan. So definitely the femoral head was done, column plate was removed, and somewhat of malunion was there. So definitely the posterior lag screws was intact. So whichever the plate screws, whichever was instructing was hindering was removed, and the same head which was taken we used as a graft. So this is how we can see the head can be used as a graft for the posterior superior defect. Then we are fixed with the 2 screws, and this uncemented cup is done. So this is a post-op X-ray. So coming to conclusion, so in this talk we have seen how to identify neglected hip dislocation, neglected posterior wall fractures, and what is the treatment protocol when there is when the elementary fracture type or associated fracture type, how you this, if there is a malunion, non-union, how you decide upon the fracture fixation, whether to do a bone grafting or this. So generally try to do whenever fixation possible, try to maintain the bone stock, try to prevent the pelvic discontinuity as much as possible, put a plate, and when if the femoral head goes for AVN, always you have a good bone stock to do a total hip replacement, because when doing in young patient also you should see to that you have a good bone stock, minimum bone stock is taken, so that in future you can have a revision bone stock for a revision arthroplasty. So thank you for giving me this opportunity, and thank you for harvardglobal.com, and this is the Twitter handle, this is a web website, and this is a good initiative. And any questions, I like to take it. And thank you for this opportunity.